testis, and Campbell 12th edition, chapter 76. So, for my references, so yung Campbell 12th edition and NCNN guidelines. So for my objectives, to identify the different neoplasms of the testis, to familiarize with the diagnostic modalities being used for testicular masses, and to enumerate the different management of testicular CA. So let's for a brief anatomy lang for our topic. So the testicles are paired organs within the scrotum that have reproductive and endocrine functions. The dimensions of the normal testis include the length of 4 to 5 centimeter and a width of 3 centimeter and a depth of 2.5 centimeter, and has a volume of 15 to 25 ml. And there's a tough capsule envelopes the testis, composed from external to internal of the visceral tunica vaginalis, the tunica albuginea, and the tunica vasculosa, before reaching the parenchyma of the testis. And each seminiferous tubule in the normal testis contains the developing germ cells. The testosterone-producing Leydig cells are interdispersed in the loose tissue around the seminiferous tubules. So there's also a small pedunculated or sessile body at the upper pole of the testis, which is known as the appendix testis. For the arterial supply, so there are 3 arterial supplies to the testis: the testicular artery, the artery of the vas deferens, and the cremasteric artery. And the testicular artery is the main blood supply to the testis, and its diameter is greater than the deferential and cremasteric arteries combined. And the testicular artery arises from the abdominal aorta and descends into the intermediate stratum of the retroperitoneum to enter the internal inguinal ring. For the venous drainage, unlike most other venous patterns in the human body, veins within the testis do not travel with their corresponding arteries. Small parenchymal veins drain into either group of veins near the mediastinum testis or veins on the surface of the testis. And these 2 groups of veins anastomose with each other and the differential veins to form the pampiniform plexus. So the pampiniform plexus is a network of testicular veins that anastomose as they ascend surrounding the testicular artery. And ultimately, these veins join to form 2 or 3 veins at the level of the inguinal canal, and they form the one vein that ascends to drain into the inferior vena cava on the right and into the renal vein on the left side. And this allows for a countercurrent heat exchange that cools the blood flow within the testicular artery. The lymphatic drainage, lymphatic channels from the testis drain into the para-aortic and inter-aortocaval lymph nodes. Visceral innervation to the testis and epididymis arise in the renal and aortic plexus and course alongside the gonadal vessels. And the genital branch of the genitofemoral nerve primarily supplies sensation to the parietal and visceral tunica vaginalis and the overlying scrotum. For the epididymis, it is a duct or tubule that is attached to the posterolateral aspect of the testis and is nearest to the testis at its upper pole, and its lower pole is connected to the testis with fibrous tissue. And there are 2 primary types of cells throughout the epididymis: the principal cells and the basal cells. The arterial supply is the branch of testicular artery, which supplies the caput and the corpus epididymis. And the differential artery also provides vascular supply to the epididymis. The venous drainage is through the vena marginalis of Haberer, draining into the pampiniform plexus by the vena marginalis testis or through deferential or cremasteric veins. And lymphatic drainage is through the channels that travel within the internal spermatic vein, draining to the pre-aortic nodes. And the nerve supply is the superior portion of the hypogastric plexus and the pelvic plexus, which yield the intermediate and inferior spermatic nerves, respectively, which innervates the epididymis. For the vas deferens, it's also known as ductus deferens and extends from the distal end of the cauda epididymis. It is a tubular, and its embryologic origin is the mesonephric or the Wolffian duct. And the vas deferens travels posteriorly along the spermatic cord behind the vessels in the cord, and the vas deferens passes through the inguinal canal and enters the pelvis lateral to the epigastric vessels. Its arterial supply is the superior vesical artery, which gives off the differential artery, which then supplies the vas deferens. And the venous drainage of the scrotal vas deferens is via the differential vein, which drains into the pampiniform plexus. And the pelvic vas deferens venous drainage is to the pelvic venous plexus. And for the lymphatic drainage, it drains from the vas deferens, travels to the external and internal iliac nodes. And nerve supply receives sympathetic and parasympathetic innervation. For the seminal vesicles and ejaculatory ducts, so it is a lateral outpouching of the vas deferens. And for the ejaculatory ducts are positioned at the junction of the vas deferens and the seminal vesicle. And they ultimately empty through the verumontanum in the prostatic urethra. And its arterial supply originates from the superior vesical artery, which branches into the vesiculo-deferential artery. And the venous drainage of the seminal vesicle follows the arterial supply draining through the vesico-deferential veins and inferior vesical plexus to the pelvic venous plexus. Its lymphatic drainage is in the interior iliac nodes, and the nerve supply is the parasympathetic innervation originates from the pelvic plexus with the sympathetic nervous system contributing fibers from the hypogastric nerves and the superior lumbar nerves. And the pelvic plexus innervates the ejaculatory ducts. So now we go on with the testicular neoplasm. So here, 95% are germ cell tumors, and for the germ cell tumors, 95% of it arises from the testes, and 5% are extragonadal. And most extragonadal develop in the midline anatomic locations, which are your mediastinum and retoperitoneum. So the theories regarding this is they originate from germ cells that mismigrated along the genital ridge and were able to survive in an extragonadal environment. And the migration from the testis to the extragonadal location. And GCTs are also categorized as seminoma and non-seminoma. For the epidemiology of GCTs, usually it's the incidence of bilateral GCT is approximately 2%, and most common malignancy in men is between 20 to 40 years old, peaking at ages 25 to 35, then slowly declines. And it's also the second most common cancer after leukemia among adolescent boys 15 to 19 years old, and majority of bilateral GCTs are metachronous. And most common to sa mga European and least common among African and Asians. For the risk factors includes white race, cryptorchidism, because men with cryptorchidism are 4 to 6 times more likely to be diagnosed with testis cancer in the affected gonad, but relative risk falls 2 to 3 times if orchidopexy is performed before puberty. And also noted that contralateral descended testis is also at a slightly increased risk. Another risk factor is your family history of testis cancer and personal history of testis cancer. And last would be germ cell neoplasia in situ, which is also known as intratubular germ cell neoplasia. The germ cell neoplasia in situ develops from the arrested primordial germ cell or gonocytes that fail to differentiate into pre-spermatogonia. So for the pathogenesis and biology of GCTs, so the carcinogenesis of GCTs is poorly understood. And the increased incidence of testis cancer that started in the first half of the 20th century has been accompanied by increased incidence of other male reproductive disorders such as hypospadias, cryptorchidism, and subfertility. And these findings led to the hypothesis that testis cancer and these other disorders resulted from a testicular dysgenesis syndrome, which in turn resulted from the environmental and or lifestyle factors and genetic susceptibility. So here is the table wherein it explains that the testicular dysgenesis syndrome is a male reproduction related condition characterized by the presence of symptoms and disorders such as hypospadia, cryptorchidism, poor semen quality, and testicular cancer. And the testicular dysgenesis syndrome hypothesis proposes that testicular dysgenesis, which has various primary causes, can lead to abnormalities in the Sertoli and in Leydig cell function. And this leads to both impaired germ cell development and hormonal changes during male sexual differentiation. So, for example, here if there is an insufficient production of testosterone, can result in incomplete masculinization, which produces results into hypospadia, and for reduced expression of insulin-like factor 3 can lead to incomplete testis descent. For germ cell tumors, they are sensitive to cisplatin-based chemotherapy, and close relationship between GCTs and embryonal stem cells and gonocytes, which have low threshold for undergoing apoptosis in response to DNA damage. An expression pattern of genes controlling the G1 to S1 phase checkpoint in GCTs appear to promote apoptosis. And in addition, the GCTs lack transporters to export cisplatin from the cells and have a reduced ability to repair cisplatin-induced DNA damage. And GCTs have a high intrinsic levels of P53 protein. And that P53 protein plays a role in mediating cell cycle and apoptosis. So for the histological classification of our GCTs, so yung GC germ cell neoplasia in situ derived and your non-germ cell neoplasia in situ derived. And for the germ cell neoplasia in situ derived, it is a breakdown into your seminoma and your non-seminoma. And for your non-seminoma, this includes your embryonal carcinoma, yolk sac tumor, teratoma, and choriocarcinoma. So for seminoma, seminoma is the most common type of GCT. It occurs in 4th or 5th decade of life, and syncytotrophoblast can be identified in 15% of cases, which stands for HCG. And it's also associated with increased incidence of sarcoidosis. And it arises from the germ cell neoplasia in situ and is considered to be the common precursor for other non-seminoma germ cell tumor subtypes. For your spermatocytic tumors, it is previously known as spermatocytic seminoma. It is a benign tumor, almost always cured with orchiectomy. And it's used to be classified as a subtype of seminoma, but is now considered a distinct entity from seminoma and other GCTs. It also does not arise from your germ cell neoplasia in situ, and its peak incidence is 6th decade of life. Excuse me. And for your embryonal carcinoma, it consists of undifferentiated malignant cells resembling epithelial cells from early stage embryos with crowded pleomorphic nuclei. And the aggressive tumor associated with a high grade of metastasis in the context of normal serum markers. It is also the most undifferentiated cell type of non-seminoma germ cell tumor with totipotential capacity. So meaning totipotent, having the ability to give rise to unlike cells, to differentiate to other non-seminoma germ cell tumors like teratoma within the primary tumor or at metastatic sites. For your choriocarcinoma, it is a rare and aggressive tumor that is typically seen with extremely high elevated serum HCG levels and disseminated disease. It is spread by hematogenous route and composed of syncytotrophoblast and cytotrophoblast and are associated with hormonal disturbances. And usually the stimulation of receptors for TSH and LH by HCG can result in hyperthyroidism and elevated androgen production. And hyperprolactinemia has also been reported. So the metastasis includes the lungs, the livers, and the brains. And usually for choriocarcinoma, the areas of hemorrhage and necrosis are prominent, like here. For your yolk sac tumors, so it is also called as endodermal sinus tumors and may grow in a glandular, papillary, or microcytic pattern. Usually, Schiller-Duval bodies is seen in half of the cases and always produce AFP, but not HCG. For your teratomas, it contains well or incompletely differentiated elements of at least 2 or 3 germ cell layers, which are your endoderm, mesoderm, and ectoderm. and classified into well-differentiated, which are your mature teratomas, and incompletely differentiated, which are your immature teratomas. And in adolescent and males, there is no clinical significance between the mature and immature teratomas. Histopathologists do not typically distinguish between the two entities. And usually they have normal serum tumor markers, but cause elevated serum AFP levels. They are usually resistant to chemotherapy, and they may transform into somatic malignancy like your adenocarcinoma, rhabdomyosarcoma, or primitive neuroectodermal tumor. So for your testicular masses, so the usual presentation is of testis cancer is painless testis mass, and regional or distant metastasis at diagnosis is present in approximately 2/3 of non-seminoma germ cell tumors and 15% of pure seminomas. And symptoms related to metastatic disease are the presenting complaint in 10% to 20% of patients, and approximately 2% of men have gynecomastia. The gynecomastia may be due to the elevated serum HCG levels, decreased androgen production, or increased estrogen levels. And if the presentation is with pain, most likely the non-seminoma germ cell tumor was caused by rapid expansion of the testis resulting from the intratumor hemorrhage or infarction caused by the rapid tumor growth. And although approximately 2/3 of men with germ cell tumor gave diminished fertility, it is an uncommon initial presentation. For the physical exam, usually we have to carefully examine the affected and the normal contralateral testes, noting their relative size and consistency, and palpating for any testicular or extratesticular masses. Atrophy is common, particularly in patients with history of cryptorchidism, and any firm area within the testis is considered suspicious for malignancy. And hydrocele may accompany a testis cancer and impair the examiner's ability to evaluate the testis, and examine for any evidence of palpable abdominal mass or pain, inguinal lymphadenopathy, and auscultation of the chest for intrathoracic diseases. For your differential diagnosis, usually is a firm intratesticular mass should be considered cancer until proven otherwise, and should be evaluated further with scrotal ultrasound. And in patients with presumptive diagnosis of epididymoorchitis, patients should be re-evaluated within 2 to 4 weeks of completion of appropriate course of oral antibiotics. And a persistent mass or pain should be evaluated further with a scrotal ultrasound. And testis cancer patients are typically young and may be less inclined to seek medical evaluation for symptoms because of denial, ignorance, or limited access. And prior studies showed that up to 1/3 of testis tumors are initially misdiagnosed as epididymitis or hydrocele. And the interval of delay is associated with advanced clinical stage, suboptimal response to chemotherapy, and diminished survival. And diagnostic delay can be avoided by efforts to improve patient and physician education. And physicians must consider the diagnosis of GCT in any male aged 15 to 50 years old with the firm testis mass, midline retroperitoneal mass, or mass in the left supraclavicular fossa. For your diagnostic testing and initial management, so first off is scrotal ultrasound. So this is widely available, inexpensive, and non-invasive. So typical GCTs are hypoechoic, and 2 or more distinct lesions may be identified. For non-seminoma germ cell tumors, usually present with heterogeneous ecotexture within a lesion is seen. And seminomas has a homogeneous ecotexture, and presence of increased flow within the lesion on color Doppler is suggestive of malignancy. And in men with advanced GCT and normal testicular examination, scrotal ultrasound should be performed to rule out the presence of a small impalpable scar or calcification indicating a burned out primary testis tumor. Usually, radical orchiectomy is performed in patients with sonographic evidence of intratesticular lesions. So usually yung intratesticular lesions, usually they describe it as with having a discrete nodule, stellate scar, and coarse calcification. Next up is your magnetic resonance imaging. So in cases of ultrasound findings are equivocal or suboptimal, MRI with enhancement is a helpful tool to distinguish between intratesticular versus extratesticular lesions and neoplastic versus non-neoplastic entities. Another helpful diagnostic modality would be your serum tumor markers. So here, they should be obtained at diagnosis after orchiectomy to monitor for response to chemotherapy and to monitor relapse in patients on surveillance and after completion of therapy. So for your non-seminoma germ cell tumors, usually both AFP and HCG are elevated. And specifically for your embryonal carcinoma, they are both elevated. For your choriocarcinoma, HCG is elevated, and for your yolk sac tumor, AFP is elevated. For teratomas, normal serum tumor marker, but cause mildly serum increased in serum AFP. And for your seminoma, increased in the HCG. So for your half-lives, so take note of this. For your AFP, half-life is 5 to 7 days, and HCG half-life is 24 to 36 hours, and LDH half-life is 24 hours. And the presence of a newly elevated and or rising serum tumor marker, even after surgery, indicates the presence of metastatic disease and should receive induction chemotherapy. So the diagnostic dilemma, usually if there is a presence of a small, less than 10 millimeter impalpable intratesticular lesions in the absence of disseminated GCT or elevated serum markers. And the majority of lesions are benign, like your testicular cyst, small infarcts, Leydig cells, nodules, or small Sertoli cell tumors. The risk of malignancy increases with the size of the lesion. And management include inguinal orchiectomy, testis sparing surgery, close observation with serial sonographic evaluation. Intraoperative ultrasound is useful during surgical exploration of the testis to locate the lesion. For your radical inguinal orchiectomy, it establishes the histologic diagnosis and the primary T stage. So it provides also the important prognostic information from the tumor histology, and it's curative in clinical stage 1 seminoma in 80 to 85% and clinical stage 1 non-seminoma germ cell tumors 70 to 80%. It also should be performed in a timely manner, and delays greater than 1 to 2 weeks should be avoided because of the rapid growth of GCTs. So here is your TNM staging for your testicular CA. So take note of it na lang. Medyo mahaba lang, but yun nga, it is based on your NCCN guidelines. But read on it na lang. For your clinical staging, so for your clinical stage 1, usually it's clinically confined to the testes. And for the clinical stage 2, it indicates the presence of regional lymph node metastasis. And for your clinical stage 3, it represents non-regional lymph node and or visceral metastasis. And your pathological staging of the abdomen and pelvis, so PN0, there is no regional lymph node metastasis. And your PN1, if there is less than 5 lymph nodes involved, and none of more than 2 centimeter. And PN2, more than 5 lymph nodes were involved, and any lymph node of 2 to 5 centimeter. And PN3, any lymph node of more than 5 centimeter. Next up would be your testis sparing surgery. It is also known as partial orchiectomy. So this is a may be considered for the organ confined tumors smaller than 2 to 3 centimeter in patients with synchronous bilateral tumors or tumor in a solitary testis with a sufficient testicular androgen production. Usually, it warrants to do a rush frozen section to distinguish between benign and malignant, and biopsy of an adjacent testicular parenchyma should be performed to rule out the presence of germ cell neoplasia in situ. And for patients with germ cell neoplasia in situ, adjuvant radiotherapy to the residual testis using doses of at least 20 grays is sufficient to prevent the development of GCT while preserving Leydig cell function. For your contralateral testis biopsy, usually between 5 to 9% of patients with GCT have germ cell neoplasia in situ in the normal contralateral testis. And in patients with an atrophic testis, history of cryptorchidism, or age less than 40 years old, the risk is up to 36%. So open inguinal biopsy of the contralateral testis may be considered. So here is the drainage. You see, so as you can see here, for your germ cell tumors, so for your right testis, so your drainage would be your interaortocaval lymph nodes, your paracaval lymph nodes, and your para-aortic lymph nodes. For your left testis is your para-aortic and interaortocaval lymph nodes. So the most common route of disease dissemination is via lymphatics, except for the choriocarcinoma, which is via the hematogenous spread. Retroperitoneum is the initial site of metastatic spread in 70 to 80% of patients with GCTs. And and the pattern of lymph drainage in the retroperitoneum is from right to left, and retroperitoneal lymphatics drain into the cisternae chyli behind the right renal artery and right crus of the diaphragm. So for your clinical staging of the abdomen and pelvis, the CT with oral and IV is the most effective non-invasive means of staging the retroperitoneum and pelvis. It provides detailed anatomic assessment of the retroperitoneum to identify the anatomic anomalies that may complicate subsequent retroperitoneal pelvic lymph node dissection. And enlarged retroperitoneal lymph nodes are found in seminomas in 10 to 20% and 60 to 70% in non-seminoma germ cell tumors. And usually there's a size cutoff of 10 millimeters is frequently used to identify enlarged lymph node reported for clinical stage 1 non-seminoma germ cell tumor in the presence of a normal CT scan. And retroperitoneal lymph nodes of 5 to 9 millimeters in size in the primary landing zones should be viewed with suspicion for regional lymph node metastasis. And size cutoff of 4 millimeters in the primary landing zone and 10 millimeter outside this region was associated with the sensitivity and specificity of for pathologic stage 2 disease of 91 and 50% respectively. And currently, there's no role for FDG PET in the routine evaluation of non-seminoma germ cell tumor and seminoma at the time of diagnosis. For chest imaging, so all patients with GCT should undergo chest imaging before management decisions. So it's important to obtain chest radiographs at the time of diagnosis as an initial staging study, and CT scans should be performed in patients with elevated post-orchectomy serum tumor markers, evidence of metastatic disease by physical examination, or abdominal pelvic CT imaging, or abnormal or equivocal findings on chest X-ray. And we can also do a brain CT imaging for elevated HCG of more than 10,000 mu per ml associated with metastatic choriocarcinoma, which is the propensity for brain metastasis. Thoracic mets in the absence of retroperitoneal disease and or elevated serum tumor markers is uncommon. So here, the International Germ Cell Cancer Collaborative Group, or the IGCC-CG, made a guide for prognostic classification of advanced germ cell tumors. So this should be used to guide treatment decision making on the choice of chemotherapy. So they classified it into the good prognosis, your intermediate prognosis, and your poor prognosis. So for your non-seminoma, the good prognosis includes a testicular or retroperitoneal primary and non-pulmonary visceral metastasis with good markers on AFP, HCG, and LDH. While on seminoma, any primary site with non-pulmonary visceral metastasis and normal AFP, HCG, and LDH. And for your intermediate, usually there's a testicular or retroperitoneal primary and no non-pulmonary visceral metastasis, and intermediate markers for your AFP between 1,000 to 10,000, HCG of 5,000 to 50,000, LDH of more than 1.5, and not more than 10. And for your poor prognosis, usually it's with mediastinal primary or non-pulmonary visceral metastasis, and or poor serum markers of your AFP, HCG, and LDH. For your sperm cryopreservation, so yun nga, although infertility is uncommon presentation for GCT, still there is the presence of oligospermia among 52% and azoospermia in 10% at the time of diagnosis. And almost all patients will become azoospermic after chemotherapy. But due to 50 and 80% of patients with normal semen parameters at diagnosis will return to these levels within 2 and 5 years respectively. And recovery of spermatogenesis after radiation therapy for seminoma may take 2 to 3 years or more. And retroperitoneal pelvic lymph node dissection may result in ejaculatory dysfunction in 80%. So men are recommended to undergo sperm cryopreservation before treatment is initiated. For your germ cell neoplasia in situ, so it is diagnosed by testicular biopsy, and the rationale for treatment is based on the high risk for developing invasive GCTs. Treatments include your radical orchectomy, low-dose RT, and close observation, and the choice of therapy should be individualized, meaning it's based on the patient's desire for future paternity, presence of or absence of normal contralateral testis, and patients desire to avoid testosterone replacement therapy. Testosterone replacement therapy is required and should be monitored for adequate testicular androgen production. So here, so this is the based on the NCCN guidelines. This is your latest for your testicular cancer non-seminoma. For stage 1, without risk factors and with risk factors. So the primary treatment is surveillance, nerve-sparing RP-LND, or primary therapy with 1 cycle of your bleomycin, etoposide, and cisplatin. So here, to further break it down, so in surveillance, the rationale for the surveillance is based on the fact that 70 to 80% of patients with clinical stage 1 non-seminoma germ cell tumor are cured by orchectomy alone. And the ability to salvage virtually all relapsing patients with chemotherapy based on the long-term cure rates achieved for chemotherapy for good risk metastatic non-seminoma germ cell tumor. And surveillance offers the potential of reducing treatment-related toxicity by restricting treatment to those with a proven need for it. And for your RP-LNDs, the rationale for this for clinical stage 1 non-seminoma germ cell tumors is based on several factors. One is that the retroperitoneum is the most common site of occult metastatic disease, and the risk for associated systemic disease is low, and 15 to 25% incidence of a systemic relapse, defined as a relapse with elevated serum tumor markers and or tissue other than the retroperitoneal lymph nodes. So like your lymphovascular invasion, retroperitoneal teratoma in those with occult metastasis. And third is low risk of abdominal pelvic recurrence after full bilateral template, RP-LND, thereby obviating the need for routine surveillance CT imaging. And RP-LND also has a high cure rate for after RP-LND alone for patients with low volume PN1 retroperitoneal malignancy and teratoma. And fifth is the avoidance of chemotherapy in more than 75% of or more of patients if adjuvant chemotherapy is restricted to those with extensive retroperitoneal malignancy. And sixth, usually it's a high salvage rate of relapses with good risk induction chemotherapy. For your primary chemotherapy, for your BEP, the rationale for this is based on the efficacy of 2 cycles of chemotherapy to eradicate the micrometastatic disease when given as adjuvant therapy after RP-LND, and the 20 to 25% need for chemotherapy despite the RP-LND. And primary chemotherapy is thus associated with the lowest risk of relapse. But these relapses are less amenable to salvage therapy because they are chemo-resistant, particularly if they have received a regimen other than the standard dose of BEP. In contrast, patients who relapse after RPLND or on surveillance are chemotherapy naive and are cured with chemotherapy in virtually all cases. However, the overall cure rate, more than 99%, is similar with both approaches. Next up would be your stage 2A and stage 2B. So there, if the markers are negative, so we could do a nerve sparing RPLND or a primary chemotherapy BEP for 3 cycles or EP for 4 cycles. And for stage 2B, for markers, negative markers, we could do a lymph node metastasis with lymphatic drainage sites within the lymphatic drainage sites and multifocal symptomatic lymph node metastasis with aberrant lymphatic drainage. So usually you could do a primary chemotherapy for BEP for 3 cycles or etoposide and cisplatin for 4 cycles. So yan, basahin na lang, medyo mahaba kasi. So here. So here's the follow-up for your non-seminoma. Now, for your seminoma, here for stage 1A and 1B, there are also 3 ways to manage it. Is one by surveillance for PT1 to T3 tumors, which is the preferred management. We could also use a single agent carboplatin or radiotherapy. So for your primary first up is for surveillance. So this is the preferred management. So here, compared with the non-seminoma germ cell tumors, surveillance for clinical stage 1 seminoma is complicated by the limited utility of serum tumor markers to detect relapse, and the need for long-term surveillance, CT imaging, because 10% to 20% of relapse occurs 4 years or more after the diagnosis. And the 5-year relapse-free survival ranges from 80 to 86%, and cancer-specific survival approaches 100%. 84 to 100% of patients relapse in the retroperitoneum, and 18 to 24% of patients have bulky retroperitoneal disease and or distant metastasis at the time of recurrence. And to detect and treat recurrences at an early stage, patients on surveillance should be followed with a clinical assessment, chest X-ray, serum tumor markers, and CT abdominal pelvic imaging. And surveillance schedules employ assessments every 2 to 4 months in years 1 to 3, every 6 months in years 4 to 7, then annually thereafter. For your chemo, usually the primary chemotherapy with 1 to 2 cycles of single agent carboplatin. So the rationale for this is based on the 65 to 90% reported complete response rates observed among patients with advanced seminoma. And for your primary RT, the optimal radiation dose has not been defined, and most centers use the 25 to 35 gray in 15 to 20 daily fractions. And the most common sites of recurrence are the thorax and left supraclavicular fossa, and virtually all recurrences are cured with first-line chemotherapy. And the surveillance of patients after radiotherapy consists of regular clinical assessment, chest X-ray, and serum tumor markers. So here, for your stage 2, you can read on it na lang in your follow-up. So now, for your relapse seminoma, yung the chemotherapy-naive seminoma relapse, so patients who relapse after single agent carboplatin are considered to have chemotherapy-naive relapse and should receive first-line cisplatin-based chemotherapy. So for the chemotherapy-naive relapse occurs in men with clinical stage 1 seminoma on surveillance, and in those with clinical stage 1 to 2B seminoma treated with primary radiotherapy. And for the former patients, radiotherapy is employed for treatment of relapse in 73 to 88% of patients, and cure rates of 70 to 90% are reported. And first-line chemotherapy cures virtually all patients who relapse outside the retroperitoneum after primary radiotherapy. And for your post-chemotherapy seminoma relapse early, an estimated 15 to 20% of advanced seminoma patients relapse after induction chemotherapy, including 10% who achieve an initial complete response. So an important consideration for advanced seminoma patients who relapse after first-line chemotherapy is the potential for teratoma at the time of relapse. Thus, patients with normal serum tumor markers should undergo biopsy before starting the second-line chemotherapy. And for your post-chemotherapy seminoma relapse late, usually late relapse of seminoma may have a favorable prognosis, particularly among patients without prior exposure to cisplatin. About 1% of men with disseminated germ cell tumor have brain metastases detected before initiating chemotherapy. And brain metastases are associated with choriocarcinoma, as previously mentioned, and should be suspected in any patients with a very high serum HCG level, so yung more than 10,000. And choriocarcinomas are highly vascular and tend to hemorrhage during chemotherapy. And death rates of 4% to 10% resulting from intracranial hemorrhage have been reported. And men who relapse in the brain after achieving a complete response to chemotherapy appear to have a worse prognosis than those with brain involvement at diagnosis. And patients with brain metastasis at diagnosis should receive a BEP for 4 cycles, followed by resection of residual masses. And patients who relapse in the brain after first-line chemotherapy should be treated with second-line chemotherapy, followed by resection and or radiation therapy. So testis cancer treatment sequelae can be divided into late and early complications. For your early toxicity, usually cisplatin-based chemotherapy is associated with numerous early complications and side effects, including fatigue, myelosuppression, infection, peripheral neuropathy, hearing loss, diminished renal function, and death. And most men are able to father children after treatment for GCT, but paternity rates are lower for men treated with radiation therapy and or chemotherapy. And early complications of radiotherapy include fatigue, nausea, vomiting, leukopenia, and dyspepsia. And late toxicity includes a peripheral neuropathy, Raynaud's phenomenon, hearing loss, hypogonadism, infertility, secondary malignant neoplasms, and cardiovascular disease. And the risk of second malignant neoplasm is a particular concern. And the incidence of a non-germ cell malignancy is 60 to 100% higher in GCT survivors treated with cisplatin-based chemotherapy or radiation therapy compared with the general population, and 200% higher in patients who receive both radiation and chemotherapy. So in summary, so all treatments for GCT, either surgery, radiotherapy, and chemotherapy, are associated with risk of early and late toxicity. And the most concerning late complications are your cardiovascular diseases and survival of motor neurons. And with the successful cure of patients, even those with advanced disease, is an important treatment objective. An important treatment objective for this is minimizing the treatment-related toxicity without compromising your curability. Now we go on to our 6 cord stromal tumors. So this includes your Leydig cells, Sertoli cells, granulosa cells, fecal cells. So here, 90% are benign and 10% are malignant. For your Leydig cells, it accounts for 75 to 80% of your 6 cord stromal tumors and is not associated with your cryptorchidism. For adults, it presents as a painless testis mass, testicular pain, gynecomastia, impotence, decreased libido, and infertility. And for children, there is a testis mass with isosexual precocious puberty, wherein there is prominent external genitalia, pubic hair growth, and masculine voice. And you usually have to check the LH, FSH, testosterone, estradiol, and estrogen. And usually Ranke crystals are seen in 30% of Leydig cell tumors. And the most frequent metastatic sites include your retroperitoneum and lungs. And for treatment, includes testis sparing surgery for lesions of less than 3 cm with rush frozen section. and radical orchiectomy if GCT or malignant. For your Sertoli cell tumors, it's less than 1% of your testis neoplasms, and it's associated with your Pooh-Jaeger syndrome and androgen insensitivity syndrome. It is not associated also with your cryptorchidism, and treatment includes your testis sparing surgery for lesions of less than 3 cm and radical orchiectomy if GCT or malignant. For your granulosa cell tumors, it is rare, and a juvenile type is benign and is the most frequent congenital testis tumor. And gynecomastia and increased estrogen secretions are common, and treatment includes your testis sparing surgery for lesions of less than 3 cm with rush frozen section and radical orchiectomy if GCT or malignant. Your gonadoblastoma, it is a mixed germ cell sex cord stromal tumor composed of seminoma-like germ cells and sex cords showing Sertoli differentiation. It's exclusively in patients with dysgenic gonads and intersex syndromes. And 80% are phenotypic females, almost always with cryptorchidism, hypospadias, some form of female internal genitalia, and considered to be in situ form of malignant GCT. And treatment is bilateral orchiectomy is required because of the risk of bilateral tumors for 40%. Now we go on to your to our miscellaneous testis neoplasms, which include your dermoid and epidermoid cyst and adenocarcinoma of the rete testis. For dermoid and epidermoid cyst, it is a rare benign neoplasm arise from the benign germ cells with retained embryonic properties or from displaced metaplastic mesothelial cells. Usually, they present on ultrasound as an onion peel or target appearance, as in here. And they do not exhibit flow or enhancement on Doppler ultrasound and MRI. And dermoids usually presents, there's a presence of adnexal structures such as glandular elements, adipose tissue, and cartilage. Treatment includes your enucleation or partial orchiectomy. For your adenocarcinoma of the rete testis, it is a rare but highly malignant neoplasm arising from the collecting system of the testis. It is a painless testis mass with hydrocele, and more than 50% have metastatic disease. Median survival rate is 1 year, and RPL and D may be curative in patients with limited RPL and metastasis. Chemotherapy and radiotherapy are ineffective. Now we go on with our secondary tumors of the testis, which include your lymphoma, leukemic infiltration, and metastases. Our lymphoma, primary testicular non-Hodgkin lymphoma, is a rare tumor and represent only 1 to 2% of all cases of lymphoma. Non-Hodgkin lymphoma is the most common testicular neoplasm on men over age 50. And bilateral testicular involvement occurs 35% of cases, usually presents as a painless testicular mass with systemic symptoms of fever, night sweat, and weight loss. Initial treatment is radical inguinal orchiectomy, and overall, it has a poor prognosis. Your leukemic infiltration, so the testis is a frequent site of relapse in boys with acute lymphocytic leukemia, and diagnosis can be made by biopsy, and orchiectomy is unnecessary. Usually, it's a local control with a low-dose RT of 20 gray, and treatment should include contralateral testis because of bilateral involvement. Overall, it also has a poor prognosis. Now, for testicular metastasis, so metastases to the testis are rare, and usually the most common primary tumors for this are your prostate, your lung, melanoma, colon, and kidney cancer. And although treatment is largely dictated by the primary tumor, orchiectomy may be considered for palliative reason. Now, we go on with our tumors of the testicular adnexia. Your adenomatoid tumor, cystadenoma, mesothelioma, and sarcoma. So adenomatoid tumor, it is usually mesothelial in origin and is the most common paratesticular tumor, 75% of which involves your epididymis, although these tumors may also arise within the testicular tunicles or the spermatic cord. And the most common presentation is a small, painless paratesticular mass detected on routine examination. in a male in the 3rd or 4th decade. It's usually benign, and treatment includes inguinal exploration and surgical excision. In cyst adenoma of the epididymis corresponds to a benign epithelial hyperplasia. Usually, these lesions are usually multicystic, and the walls of which are studded with nodules of epithelial cells arranged in a glandular or papillary configuration. And one-third of cases are bilateral and occurs in patients with von Hippel-Lindau syndrome. Your mesothelioma arises from the tunica vaginalis, is seen as a painless paratesticular mass or tunical vegetations in association with hydrocele. It is a benign, usually benign and malignant mesothelioma distinction is based on their atypia, mitotic activity, and invasion. Most common risk factor is asbestos exposure, and treatment includes your radical inguinal orchiectomy and hemiscrotectomy. Overall prognosis is poor, of less than 2 years. And last is your sarcoma, and liposarcoma is the most common malignant histologic subtype in adults, followed by your leiomyosarcoma, malignant fibrous histiocytoma, rhabdomyosarcoma, and last is your fibrosarcoma. So embryonal rhabdomyosarcoma is the most common in men of less than 30 years old. It is a painless, palpable mass and large of more than 5 centimeters. And usually they present a solid mass in the scrotum external to the tunica albuginea, should be explored through an inguinal approach, and biopsy should be performed. And it's usually managed initially with wide excision of the spermatic cord and the testis with high ligation. And in the presence of normal metastatic evaluation, patients with sarcomas other than liposarcoma should undergo RP-LNB, and post-op chemotherapy should be given to RP-LN metastasis. And usually liposarcoma has the most favorable diagnosis, and malignant fibrous histiocytoma and leiomyosarcoma have the least favorable diagnosis. So, yan.
Thank you, Rai, for a comprehensive lecture. So do we have questions from our panel? So thank you, Ryan. For tonight's lecture, we're actually sponsored by Cathay Drug. Do we have representative? Sir JP, do you have a slide?
Hello, good morning, doctors. Yan po. Doc Rome, Doc Ryan, si Doc Yado, Doc Alpas, Doc Madrona. Ayan. Doc, good evening po sa inyo. Dito pa rin ako, Doc. JP pa rin. Hingi ko pa rin ng tulong yung fosfomycin. Hi, Doc Madrona. Good evening po, Doc Alpas. Doc Sid. Si Doc Sid.
Good evening, JP.
Good evening po.
Parang hindi ka na nagpapagupit, JP, ah.
Di pa, Doc, eh. Natatakot, Doc, eh. Madaming hinahawakan ng
yung
mga barbero. Yes, Doc. Doc, ipapakilala ko po sa inyo pala ang aming monurol specialist, si Jasmine po. Yan.
Hi, Doc. Doc, I'm Jasmine po. Ako na po yung mag-handle ng fosfomycin monurol po.
Siya na, Doc, ang magko-cover sa inyo sa veterans. Pero nandyan pa rin ako, Doc. Magko-cover ako ng ibang gamot naman sa inyo. Like cefuroxime namin na Cefurex and vitamin B complex. Doc, and si Malu pa rin. Yan, nandyan din, Doc. Thank you sa ano na to. Thank you sa Doc. Sa gabing ito na nakapag-promote ulit kami sa inyo kahit hindi tayo madalas nagkikita.
Thank you sa lunch din kanina, Sir Jay.
Yes, Doc.
Thank
you.
you.
Doctor. Good evening po.
Yung webinar sa Sabado, di ba kayong sponsor nun?
Yes, Doc.
Doctor.
Para sa PUA. Sana, Doc, maka-attend tayong lahat.
Oo, nag-register na nga kami.
Thank you, Doc. Thank you po.
Thank you,
Doc,
Doc.
salamat, Doctor.
So if we don't have any questions, we'll take a screen cap for our attendance. Ernest, sa yung laptop.
Command Shift 3. Command Shift 3.
Okay. Okay. Thank you,
Ayan.
Doc. Sige, Ryan.
Promote ko pa rin yung Monurol natin. Available pa rin. Mercury and sa hospital pharmacy po. Available pa rin tayo, Doc.
Thank you, Sir JP. Ma'am Malu.
Okay.
Ma'am Jasmine, thank you.
Doc, malu pa
Thank you,
rin,
Doc.
tatay. Ako pa rin, Doc, yung may handle ng ating si Foxitine, Monoel.
Manuel.
Available pa rin po tayo, hospital, pharmacy, butika ng bayan. And also yung ating Tamsulusine, Tamsor, for patient with BPH, Mercury available po, Doctor. And Doc, sabay ko rin yung aming bagong gamot for Euro, yung ating Bicutamide, Columbia po, 50 mg film-coated tablet po. Kung may mga cases, Doctor. Soon po available na po tayo sa Mercury Drugstore po.
Okay.
Doc,
Okay, thank you.
ulit sa
Thank you.
opportunity na to.
Cheers. Kamusta po?
Ingat po kayo lahat, Doc.
Thank
Okay,
you, Doc.
bye-bye.
Thank you po.
Thank you,
Salamat.
Doctor, sa time.